So our first topic for today is how to deal with diabetic patients before surgery. Now, what will be the management of a patient who is on oral hypoglycemic drugs? If a major surgery, then we need to stop oral hypoglycemics before surgery. And if a minor surgery, then we will continue with the same routine. What will be the management of patient on insulin? The management of the patient with insulin is that before major surgery, we need to start insulin, IV insulin on sliding scale. And continue until the diet per mouth is re-established. Or we can start IV insulin with dextrose saline. Dextrose is started with IV insulin infusion, either insulin on sliding scale. In sliding scale, the insulin is given to the patient according to his random blood sugar levels. Where another possibility is that we can start insulin infusion along with dextrose and saline. Because if we start IV infusion of insulin, then there is chance of hypoglycemia. So along with insulin infusion, we will start dextrose. And if a minor surgery and the patient is on insulin, then we need to omit the insulin on the day of the surgery. In all the cases, either if the patient is on oral hypoglycemic or if the patient is on insulin, the previous regimen will be started whenever diet per mouth is restarted or re-established. So a summary of management of diabetic patient. The pre-op management of diabetic patient. If the patient is on oral hypoglycemics, then we need to stop oral hypoglycemic before surgery. And if he has to undergo minor surgery, then he will continue the same routine. We do not need to stop the oral hypoglycemic. While in case of insulin, before major surgery, we'll shift the patient to sliding scale insulin, or we'll start an IV insulin infusion along with dextrose saline. And if minor surgery, then no need to shift the patient on IV insulin. We just need to omit the insulin on the day of the surgery. In all the cases, the previous regimen which the patient was using before the operation, that will be started when the diet per mouth is re-established. And also in all the cases, we'll check blood glucose 4-hourly. Is it clear, Adiman?
Yes, it is. Just a question about this sliding scale. What does that mean? Like it is, they keep on changing according to the level of the glucose?
Yes, on sliding scale, there are specific units of insulin for specific level of glucose. Like if the patient glucose is 250, then according to sliding scale, the units that we need to give to that patient is, I think, almost 6 to 8 units.
Okay.
For 300, they are 10. For 350, they are 12. I don't remember the exact levels, but sliding scale is according to the patient BSR levels.
Okay, thank you.
Any other questions? So our next topic is esophageal atresia. Esophageal atresia if the baby in the womb of a mother has esophageal atresia, then the female will present to you with polyhydramnios because the amniotic fluid is swallowed by the baby, and as there is esophageal atresia. What is esophageal atresia? Esophageal atresia means esophagia is ending blindly. Like in this case and in this case, you can see there is a blind end of esophagus. So there will be no swallowing of amniotic fluid, and the mother will develop polyhydramnios. On antenatal ultrasound scan, the gastric bubble will be absent. So polyhydramnios with absent gastric bubble, then the diagnosis is most likely esophageal atresia. Esophageal atresia usually diagnosed after 26 weeks of gestation, and it is associated with other defects which we collectively call as vectoral defects. V for vertebral defects, A for anal atresia, C for cardiac defects, T and E for tracheoesophageal fistula, R for renal defects, and L for limb defects. So tracheoesophageal fistula is usually present with along with other defects which are called vectoral defects. What are the complications of esophageal atresia when a baby is born? It can lead to aspiration pneumonia and gastric distension at birth. There are usually three types of tracheoesophageal atresia along with tracheoesophageal fistula. As you all know that fistula is an abnormal communication between two cavities. So in the first diagram, you can see that proximal esophagus is ending blindly, and the distal esophagus has a communication with the trachea. In diagram B, you can see that this is proximal esophagus and this is distal esophagus without any fistula or communication with the trachea. And in the third diagram, you can see this tracheoesophageal fistula is like an H-shaped. There is no esophageal atresia, but there is a tracheoesophageal fistula, a communication between trachea and esophagus. So esophageal atresia, the first type is esophageal atresia with the distal tracheoesophageal fistula, or there can be isolated esophageal atresia without any fistula, or there can be an H type of tracheoesophageal fistula. Now, this was esophageal atresia. Esophageal atresia is if a female present to you with polyhydramnios and the gastric bubble is absent on antenatal scan, then it is esophageal atresia. Now, when will you say that it's gastric atresia? When will it be duodenal atresia? And when will it be jejunal atresia? So if there's no bubble, it means no air is swallowed or no air in the stomach. So it will be esophageal atresia. But if there is a single bubble, then it is gastric atresia. And if there's a double bubble, then it is duodenal atresia. And if there's a triple bubble, then jejunal atresia. So no bubble, esophageal atresia. A single bubble, gastric atresia, means the outlet of stomach is blocked. That's why only single bubble. But if there is blockage or atresia at the level of duodenum, then there will be two bubbles, one in the gastric and other in the duodenum. But if there are triple bubble sign on X-ray, then it is jejunal atresia. There will be a bubble in the gastric area, there will be a bubble in the duodenal area, and one bubble in jejunal area. There will be no flow of air or fluid or anything beyond jejunum. So there will be a triple bubble sign on X-ray. Let's see an example. Now you can see that one bubble is this one and the other is this one. So it's a double bubble sign. It is most likely duodenal atresia. So no gastric bubble on X-ray or on antenatal ultrasound scan, then it is esophageal atresia, a single bubble, it's gastric or pylorholic atresia, double bubble, it's duodenal atresia, and triple bubble, it's jejunal atresia. The presentation of esophageal atresia is that a pregnant woman will present to you with polyhydramnios and ultrasound will show no gastric fetal bubble. Another hint for esophageal atresia is that an X-ray would show the catheter is coiled in the esophagus because there is esophageal atresia, so we will not be able to pass a catheter into the stomach. So the catheter will be coiled in the esophagus. So if a neonate present to you with this sign that catheter inability to pass catheter and an X-ray show coiled catheter in the esophagus, then it is esophageal atresia. But if an adult present to you with a coiled NG tube in the esophagus or coiled NG tube after chest X-ray, after a history of road traffic accident, then it is diaphragmatic rupture. Tenesmus. What is tenesmus? Tenesmus is a continual or recurrent inclination to evacuate the bowels caused by disorders of the rectum or other illnesses. So tenesmus can be present in the rectal carcinoma, and tenesmus can also be present in the inflammatory bowel disease such as ulcerative colitis. Because rectal carcinoma can cause tenesmus as well as inflammation of the rectum can also cause tenesmus. So these are the two important diseases which you need to remember in which tenesmus can be present. One is colorectal carcinoma or rectal carcinoma, and the other one is. Now, what are the risk factors for colorectal carcinoma? Remember that age is the most important risk factor for colorectal carcinoma. Old age is the most important risk factor for colorectal carcinoma, followed by a family history of colorectal carcinoma. So if in the exam they ask you about the most important risk factor for colorectal carcinoma, then your answer will be age. And if age is not given, then you will select family history of colorectal carcinoma. Can any one of you tell me for which cancer smoking is the most important risk factor?
Breast or ovarian cancer?
For breast cancer, BRCA1 or BRCA2 mutations are important risk factors, as well as family history.
Family
Remember
history.
that smoking is the most important risk factor for urinary bladder cancer.
Oh, yes.
So, risk factor for colorectal carcinoma include age, family history. Smoking is also a risk factor for colorectal carcinoma, polyposis syndrome, and diet that is consists of only meat or canned diet or which is low in fiber, and inflammatory bowel disease is also a risk factor for colorectal carcinoma, because in inflammatory bowel disease there is inflammation of the colon or intestine, and inflammation will leads to the increased turnover of the cell. So if cells are continuously being dividing, then there is a risk that a mutation can occur during mitosis, which can lead to colorectal carcinoma. So inflammatory bowel disease is also a risk factor for colorectal carcinoma. Firm painless mobile mass in young women breast fibroadenoma, initial investigation would be ultrasound. Remember that any swelling for general surgery, every swelling will initially be, the initial investigation in case of swelling will be ultrasound, followed by FNAC.
Excuse me, sir.
Yes,
You said tenesmus first is related to colorectal carcinoma, and the second one is, you said it is related to two.
yeah, the second one was inflammatory bowel disease such as ulcerative colitis.
Okay, sir.
Remember that ulcerative colitis affects the most commonly it affects the rectum and sigmoid. So any disease which can affect the rectum can lead to tenesmus. And colorectal carcinoma and ulcerative colitis are the two important ones. Now, the most common complication after surgery is infection. It does not matter what type of surgery is done. If they ask you about the most important complication post-operative is infection. Infection can be wound infection, or it can be lung infection, or it can be urinary tract infection. Even after hemiarthroplasty. What is hemiarthroplasty? Hemiarthroplasty is partial replacement of the hip joint. Even after hemiarthroplasty, infection is the most common complication. Not fat necrosis, not DVT, not avascular necrosis. The most common complication is always infection. DVT is not common because we all know that these days anticoagulants such as low molecular weight heparin or enoxaparin are mandatory. Now, there is a scenario for all of you. Let's see who answer this one. A 60-year-old present to the emergency department complaining of passing of large amount of bright red blood. So the patient is 60-year-old. There's bright red blood. Left lower abdominal pain for 2 days. History of abdominal pain for 2 days, that is worse after eating. Nausea but no vomiting. The patient's main diet is canned meat. There is localized left lower abdominal tenderness without rigidity or rebound tenderness. On examining the rectum, blood is found on the examiner's glove. What is the most likely diagnosis in this scenario?
Rectal carcinoma.
Colorectal carcinoma.
Colorectal carcinoma. So 60-year-old present to you with large amount of. So the points that favors the colorectal carcinoma are the patient is 60-year-old. Okay, one is that one, and he is complaining of bright red blood. Second is that left lower abdominal pain for 2 days. The history is short. Patient is giving an acute history of pain. Nausea but no vomiting. There is no mention of weight loss. The points that are not favoring colorectal carcinoma is no mention of weight loss, plus the history of the patient is very short. Only 2 days history of left lower abdominal pain. Plus there is localized left lower abdominal tenderness. What can be the other differential diagnosis in this scenario? What else can occur in old patient other than colorectal carcinoma, which can present with left lower abdominal pain?
Diverticulosis.
Diverticulosis. Can it be diverticulosis?
If it is related to infection or temperature, then it could be diverticulitis.
Yes, it can be a bleeding diverticulitis because for colorectal carcinoma,
It can be
there's no mention
polyps,
of
sir.
colorectal carcinoma. If you remember that the symptoms were old age along with anemia, along with altered bowel habits, weight loss. So it mostly looked like a case of diverticulosis or an infected diverticulum, which will cause diverticulitis. And when a diverticulum is infected, it can cause bleeding per rectum. So vital signs are, let's give you some more hints. Vital signs are BP is 85 by 55, heart rate at 105, and temperature is 38. So now what is your diagnosis? Is it colorectal carcinoma or diverticulitis?
Diverticulitis.
Diverticulitis because the patient is having temperature of 38 degrees centigrade, and also there is massive bleed, so patient is going into hypovolemic shock. So what will be the management of this patient?
IV fluids.
Yes, that's right. Admit the patient for further management for IV fluids and later blood transfusion. So you all know that yesterday or the day before yesterday we discussed how a perforated diverticulum can present to us. Now today we have discussed that a bleeding diverticulitis can mimic the colorectal carcinoma. So you need to differentiate between these two. The patient is having an acute history. First hint was that, and the other one was the patient is having temperature And also there was no mention of weight loss. So initial step is, as the patient is hypotensive, IV fluids. Simple outpouching is called diverticulosis due to low fiber diet. And when fecal is impacted in the outpouching, it can lead to inflammation or infection, which is called diverticulitis, which can result in bleeding. So it will present to you with left lower abdominal pain, fever, and constipation. The patient will be treated with IV fluids and IV antibiotics as there is infection by admitting him into the surgical ward. And in surgical ward, we will take full blood count to see the hemoglobin of the patient and to see if there's a need of a blood transfusion. And colonoscopy is used to stop the bleeding source. And if it cannot be treated with colonoscopy, then even surgery is performed in case of diverticular rupture. So in short, a patient with bleeding diverticulitis, you need to admit him urgently in the surgical ward for further management. Now, our next topic is hemorrhoids. What are hemorrhoids? Hemorrhoids are basically excess of perineal tissue which consists of normal vascular mucosal cushions. So hemorrhoids are basically excess perineal tissue. These tissues consist of mucosa, submucosa, and blood vessels, pedicles. There are two types of hemorrhoids. One is internal hemorrhoids and one is external hemorrhoids. As we have discussed previously, that the lining of the enteric tract is columnar epithelium. Starting from the stomach, in the esophagus, the epithelium is squamous, stratified squamous epithelium. Then from the stomach till this line, starting from the stomach to this line, which is called pectinate line, the epithelium of the enteric tract is columnar epithelium. And below this point, which is called pectinate line, in the anal canal, the epithelium is again squamous epithelium. So there are two types of hemorrhoids, internal hemorrhoids and external hemorrhoids. This one is a pectinate line, a hemorrhoid which is above the pectinate line or in the upper anal canal. They are called internal hemorrhoids. Here, they are internal hemorrhoids. And the hemorrhoids which are below the pectinate line or in the lower anal canal, they are called external hemorrhoids. So hemorrhoids in the upper anal canal are internal hemorrhoids, and hemorrhoids in the external anal canal or below the pectinate line are external hemorrhoids. Internal hemorrhoids can also come out of the anus if they are prolapsed. You can see in this diagram that the internal hemorrhoids have prolapsed and they have come outside. Now, grades of what are the grades of hemorrhoids? Grade 1, 2, 3, and 4. If there is only bleeding, then the grade of the hemorrhoid is grade 1. And if there's prolapse with defecation, they come out when the patient defecates, and spontaneous reduction, and they are reduced on their own, then it is grade 2. Prolapse plus spontaneous reduction, grade 2. Prolapse plus manual reduction, grade 3. Prolapse plus cannot be reduced, grade 4. I'll repeat it. Bleeding only, grade 1. Prolapse plus spontaneous reduction, grade 2. Prolapse plus manual reduction, grade 3. Prolapse with no reduction, grade 4. Grade 1 and 2 hemorrhoids does not require any surgical intervention, while grade 3 and 4 hemorrhoids are managed surgically by performing hemorrhoidectomy. So after abdominal surgery, the next topic is acute gastric dilatation. After splenectomy or removal of spleen, or during splenectomy, the blood supply to the stomach might be affected. Because there are some branches of the splenic artery or the arteries that supply the spleen, which supplies the some portion of stomach. So after splenectomy, if a patient present to you with abdominal distension, then it is most likely acute gastric distension, acute gastric dilation. For example, let's discuss a scenario. On the second day of post-splenectomy, a patient develops epigastric fullness, tenderness, nausea, and vomiting, and gradually increasing abdominal distension. He is hypotensive and tachycardic. So after splenectomy, if a patient present to you with epigastric fullness and abdominal distension, then the cause is more likely acute gastric dilatation. But in this scenario, you can see that he is hypotensive. Why is he is hypotensive? Because the dilatation of the stomach will compress the surrounding blood vessels. So that's why the patient can be hypotensive. So the main hint for acute gastric dilatation is that abdominal distension after splenectomy. What is the management of acute gastric dilatation or distension? IV fluids and NG tube. Insertion of NG tube will deflate the stomach and it will resolve the signs and symptoms. The cause of hypotension in this case is that distended stomach will compress the surrounding blood vessels and it will result in the blood pressure drop. Our next topic is carpal tunnel syndrome. Is there any question up till now? Carpal tunnel syndrome, pregnancy is an important risk factor for carpal tunnel syndrome because in pregnancy there is fluid retention, which can lead to the compression of the median nerve in the carpal tunnel. And the median nerve supplies the thumb index, middle, and half of the ring finger. So in carpal tunnel syndrome, there will be numbness or tingling sensation along the supply of the median nerve.